The next topic for discussion is diabetes and pregnancy. Most of the time when we see pregnant women who are diabetics, it's either type 1 diabetes, insulin-dependent diabetes mellitus, or type 3 diabetes, gestational diabetes, which means that they are diabetics only during pregnancy. It is rare to see a type 2 diabetic. Type 2 diabetes is the maturity onset diabetes, and usually by the time it onsets, women are past their childbearing years. If, however, you did have a type 2 diabetic who wanted to get pregnant, they really should go on insulin and not be on the oral hypoglycemic agents, because the oral hypoglycemic agents have teratogenic effects. So if a woman had type 2 diabetes, she should be on insulin prior to getting pregnant. Now, a couple of thoughts for us when we talk about diabetes and pregnancy. Maternal insulin, mother's insulin, does not cross the placenta. The baby makes their own insulin by about 12 weeks of gestation. Placental hormones are anti-insulin. They have an anti-insulin effect on the mother. And we also remember that maternal glucose crosses the placenta and acts like a growth hormone on the baby. So that means that very frequently babies of women who are diabetic are very large babies, 10, 12-pound babies. So that glucose acts like a growth hormone and makes them large babies. Remember when we said the placental hormones are anti-insulin, that means that mother's insulin needs will increase during pregnancy once those hormones are being produced. Now, in the first trimester, her insulin needs decrease because all that glucose is going to the development of the baby. Once the placenta is fully formed, her insulin needs increase. So second and third trimester, her insulin needs increase. Obviously, frequent monitoring is necessary. Usually she'll be monitored either by an obstetrician specializing in endocrine, or she'll be having two physicians, an obstetrician and also an endocrinologist. Now, it's important for us to monitor that LS ratio. When we talk about LS ratio, I think I mentioned it a little bit earlier on the tape here, but the women who are diabetic, they have vascular complications, and what's going to happen is the placenta deteriorates earlier than the placentas of non-diabetic women. So the goal is that we would hope the baby would be mature enough to be born before the placenta deteriorates. And one way to assess the maturity of the fetal lungs is to do the LS ratio. So hopefully that will be 2 to 1 before the estriol levels begin to drop, and that would suggest that the placenta is deteriorating. And that LS ratio is determined on an amniocentesis. Frequently, women will be delivered earlier, so they may have a C-section or an induction anywhere from usually 37, 38 weeks would be a good time for that. Let's look at a question. A newborn infant is with his mother, who is a diabetic. He appeared pink and alert, and his temperature was stable when he left the nursery 15 minutes ago. His mother calls the nurse and says, "Look at his legs." The nurse observes spontaneous jerky movements. What should the nurse do initially? Tell his mother this is normal behavior for a newborn. Choice 2, tell the mother to feed him glucose water now. 3, do a glucose test on the infant. 4, take the baby to the nursery and observe for other neurologic symptoms. Now, the symptoms, the data that we see with this baby with spontaneous jerky movements born to a diabetic mother might suggest to us hypoglycemia. However, before we do anything about it, we want to determine if that's the case. So the correct answer is number 3. Do a glucose test on the infant. It doesn't take very long to do a glucose test, and if indeed the baby is hypoglycemic, as you suspect he is, then once you've confirmed that with a glucose test, then you can feed the baby glucose water. Now, I think we need to look at what happens to both mom and baby after delivery. Now, after delivery, it's a little bit of a difficult process in terms of regulating insulin. Oftentimes, the mother needs less insulin for the first day or maybe even 2 days after delivery. Remember that those placental hormones were putting out anti-insulin. They have an anti-insulin effect. And now after delivery, the placenta is suddenly gone. And so you now have an absence of those anti-insulin hormones, and this puts mother at risk for hypoglycemia. This is why she may need less insulin in the postpartum period. Now, I think it's easy to remember that both mom and baby are at risk for hypoglycemia. Mom, because those anti-insulin hormones of the placenta are gone, and baby, because he's now not getting this high glucose fix, the high glucose levels that were coming through the placenta to the baby. But the baby's pancreas is on overdrive, making large amounts of insulin. So until that balances out, both mother and baby are at risk of hypoglycemia. There is no reason why a diabetic mother cannot breastfeed. That's sometimes a question they ask. So breastfeeding is perfectly fine. In fact, it's encouraged for breastfeeding mothers. We know a couple other things about diabetic moms. We know that there is statistically a higher risk of fetal anomalies. This risk is not high enough to preclude pregnancy in diabetic women, because most of the time they have perfectly normal babies. Diabetic moms have a higher risk of PIH, pregnancy-induced hypertension. We want to monitor them extremely carefully during pregnancy, because sharp fluctuations of blood sugar, and if they should go into ketoacidosis, this can be very hazardous and dangerous to the developing baby.